Okay, so let's look at cardiovascular physiology, and this is the entire cardiac cycle, a really nice slide. I know it looks very busy, but please do make it a point to kind of look at every single sort of label in this slide, because it really gives you a very, very good idea. So you can see superior vena cava, inferior vena cava, coronary sinus, bringing blood into right atrium. From the right atrium through tricuspid, right ventricle, through pulmonary to pulmonary trunk, to lungs where it gets oxygenated, all shown in blue. Then through pulmonary veins, it goes to the heart, to the left atrium. From the left atrium, through mitral valve, left ventricle. From left ventricle, aortic semilunar valve. So notice how it uses the word semilunar valves, pulmonary semilunar valves. So the aortic and the arterial valves are called semilunar, okay? And then from here, it goes to the aorta, to the body, and systemic capillary. So really important. So make sure you kind of look at this and look at all of this thing. So again, we are going to look first at cardiac cycle. So I want to kind of really push this, embed this into your heads.
Ventricular contraction causes the atrioventricular valves to close, which signals the beginning of ventricular systole. The semilunar valves were closed during the previous diastole and remain closed during this period. Continued ventricular contraction increases pressure in the ventricles above the pressure in the aorta and pulmonary trunk, causing the semilunar valves to open. When the ventricles relax and their pressures drop, blood flowing back toward the relaxed ventricles causes the semilunar valves to close, which is the beginning of ventricular diastole. Note that the atrioventricular valves remain closed. When the pressure in the ventricles becomes lower than the pressure in the atrioventricular valves open and blood flows into the relaxed ventricles. This accounts for most of the ventricular filling. The atria then contract and complete the ventricular filling.
So from this picture, tell me some of the things that you know. What did systole mean to you, and what did diastole mean to you? What was happening during systole and what was happening during diastole? Systole was ventricular contraction. Okay, very good. And what was happening during systole? The mitral and the tricuspid valves were closing. Okay, so the atrioventricular valves were closing. Very good. And
the blood was being forced upward out of the heart.
The blood was being forced upward out of the heart. Very good. Into aorta and the lungs, the pulmonary arteries. So you saw how those valves had to open. If the ventricle contracts and it goes into the arteries, those valves have to open, right? Okay. So and then blood got pushed out. Then the ventricle started relaxing. What was that called? Diastole. What happened? Did you notice what happened during diastole?
The valves that open.
Before those valves opened, valves closed, which the semilunar, which was the aortic, and the pulmonary closed. Did you also notice how they closed? You can see, remember the blood came back, and I told you all it formed those cushions on those sinuses, and that's how it closed, okay? And then these were still closed, because when this relaxes, the pressure has to fall, and then these will open when the ventricle is fully relaxed, right? And then blood flows from the atria into the ventricles. How was blood flowing from the atria into the ventricles? Very good. By gravity mostly. Did you see that? It was only towards the end that the atria actually contracted. Okay? So gravity is what pushes the blood from the atria into the ventricles. Most of it is due to gravity. Only last 25% is because of atrial contraction. And during diastole, you can see how the AV valves now had to open, because blood had to come from the atria into the ventricles, right? So we're all done. You know your cardiovascular anatomy actually. Okay? Very good. Yeah, so you can see that. So very good. So systole is ventricular contraction, diastole is ventricular relaxation. here's a few things that you can see, and again, read this very, very carefully, exactly what we just said, and you told me all of this. See, most of it fills by gravity. Atria contract towards the end, and they force that additional blood into it, and during systole, what happens. The AV valves close, and the AV valves close because the papillary muscles, what we did in cardiovascular anatomy, papillary muscles pull on the chordae tendineae, and that's how they close, okay? Now, during systole and diastole, why do you think diastole is of a variable length? Whereas if I told you, I made this statement, and this is a true statement, systole is fixed. Diastole can be of a variable length. Diastole can be a few milliseconds, or you can actually increase diastole also. What would be the most logical answer as to why systole should be fixed and why diastole should be relaxed?
It's time to fill with blood. The chambers need time to fill with
The chambers need time to fill with blood, so you should, that's why diastole can vary. Okay, good. That's one answer. Anything else? That is right, yes. Yes. When you need to fill with blood, I mean, you can fill with little blood, you can fill with more blood, so you can vary the thing. Very good. Yes.
Does it have to do with like fast twitch muscles with the contractions?
No, it doesn't have to do with fast twitch muscles, but it does have something to do with muscles.
It takes longer to relax than to contract.
No. If I told you to relax, you'd relax in a second. I told you to do some work, you would take some time. What happens when you do work? What do you need to do work? Energy, and more oxygen, right? So if I gave you a choice that you work for 1 hour and relax for 1 hour, or you work for 1 hour and relax for 30 minutes, or I gave you a choice, you work for 30 minutes and relax for 1 hour, which one would you choose? Relax for 1 hour and work for 30, right? Most of you would choose that. So why wouldn't the body do that too? Because when you work, you need a lot of energy, right? So you have to constantly provide the muscle with energy. So with the result, if you made the systole variable, the cardiac muscle is just going to be taking up so much of the energy. And you might have byproducts which would come out of it. So therefore, keep the relaxation time variable, because you're not going to expend any energy during that time. You can gather as much blood as you want, because as Fatyan said, that that's when the chamber fills up. But keep the systole fixed so that you only use this much energy and you push out blood. Another thing you can realize from this is that if you keep the diastole variable, the longer the relaxation, the more the blood in the ventricles, the more you can actually push out during systole, right? So if you fill the ventricles with 15 ml of blood, you may be able to push out only 10. If you fill the ventricles with 30 ml of blood, remember A and P, what happens when muscle is stretched? It's able to contract better. So when the ventricle is stretched with more blood, the muscle is able to contract much better. So it contracts better in 30 ml, maybe it'll push out 25 ml of blood. Got that? So those are the advantages of keeping the diastole of a variable length and keeping the systole fixed. So make sure you read this. I'm not going to go over this. It's all part of cardiovascular anatomy, but really nice slide. And I kind of highlighted some of the things, but read every kind of bit here. So here you can see as the ventricles contract, the intraventricular pressure rises, blood is pushed against the semilunar valves, it opens it because the pressure here is more than the pressure here, and blood goes into the aorta or the pulmonary artery depending on which chamber of the heart you're talking about. At the end of systole and the beginning of diastole, as the ventricles relax, when the pressure falls, we saw the blood tries to come back, so the sinuses fill with blood and the semilunar valves close at that time. So this is just again a little review about that. So venous blood from the atria goes to the atria, the pressure rises in both atria, AV valves open, causing the ventricles to fill, the ventricles contract. When they contract at the beginning of systole, first the AV valves close, then the rest of the ventricular contraction starts. Semilunar valves open, blood goes into the arteries. That's the end of contraction. The ventricles relax, which is the end of systole or the beginning of diastole. That's when the semilunar valves close. So you should know when the AV valves close and when the semilunar valves close. So AV valves close at the beginning of systole, semilunar valves close at the end of systole or the beginning of diastole. Okay? Okay, you tell me. You answer this question. When the ventricles fill with blood, which valves will remain open?
As they fill with blood.
AV valves, if the ventricles have to fill with blood, what connects the ventricles to the atria? AV valves. So they have to remain open. If they are closed, it won't work. So going back to your question, when do they open and when do they close? It really is, if you think about it logically, as I said, it's plumbing, right? So when the ventricles contract, which is the beginning of systole, you do not want the AV valves to remain open, because if they contract and the AV valves were open, blood would go back into the atria, which you don't want to happen. So at the beginning of systole, the AV valves will close. The pulmonary and aortic valves will open so that blood can go into the arteries. At the end of systole or the beginning of diastole, now blood, when the ventricles relax, blood tries to come back into the ventricles. That's when the semilunar valves, the aortic and pulmonary, will close. So that's how you're going to remember. Beginning of systole, AV valves close. Beginning of diastole, semilunar valves open. Because if the ventricle is relaxing and these valves are open, blood would come not only from the atria, they would start coming back from these arteries as well. And you don't want that to happen. Okay? So let's stop here and we'll go to this next time. So let's look at now some terms that we use with cardiovascular physiology. One is the heart rate, the number of times the heart beats per minute, okay? And that's called the resting heart rate. Now, we generally throw out a number like 72 beats per minute, but everybody is very individual. It's not, you cannot pinpoint that if you're not 72 beats per minute, there's something wrong with you. So it's really a bit of a range, and it could be anywhere from 60 to 74 and so on. People who are athletes and who train very rigorously all the time, they have a much lower resting heart rate compared to the general population, compared to someone who's very sedentary. The reason being that if say like a trained athlete's heart rate was not, like the regular range of say maybe about 70, 72 beats per minute, when that person exercises, then the heart would have to beat really, really fast. When it beats really fast, what happens? It'll keep pumping so fast, so the relaxation, the diastolic period would be much less, which means it will not be able to fill that well with blood, so it won't be able to push out that much. So their tissues will not get enough oxygen, right? So in such people, what happens is their resting heart rate is much lower than a sedentary person. In all of us, our heart rate is kept at around between, like I said, a range of about 60 to 72 beats per minute, because at resting time, which system is more active, sympathetic or parasympathetic? At rest, parasympathetic is more active, right? So as far as the heart is concerned, again, the parasympathetic system is more active compared to the sympathetic system at rest. And this parasympathetic system keeps your heart rate kind of low, around, this normal, like I said, 60 to 72 beats per minute. The parasympathetic system, if you remember from ANP1, traveled with 4 cranial nerves, the 3rd, the 7th, 9th, and 10th. So the 10th cranial nerve, the vagus, is the one which goes to the heart. So if the parasympathetic system is very active at rest, it's the part which is traveling with the vagus which is very active. So we say that at rest, the vagal tone is quite high, okay? In an athlete, this vagal tone, which means the parasympathetic system, is even higher than normal. So the parasympathetic system being so active in athletes, that keeps their heart rate low. If you were to ask any of these athletes, like a tennis player, a football player, the marathon runners and so on, it's not uncommon to find that their resting heart rate is actually around 40 beats per minute. Even you guys, you don't have to really be somebody who's kind of competing at Olympic levels. But let's say that you were someone who didn't get off the couch and you started going to the gym on a regular basis, and then you sort of take your heart rate after maybe a couple of months or so on, you will find that your heart rate will also come down. Those of you who exercise regularly, take your heart rate, and next time when we meet, tell me what your individual heart rates are, and then we'll see how it kind of varies in this class, okay? So that's called the vagal tone, which is because of the parasympathetic system. And in athletes, the parasympathetic tone or vagal tone is very high. So their resting heart rate is low, so that when they exercise, so from 40 beats per minute, it can go up to 60. You don't want, if they started with about 60 or something, you don't want it to go up to 120, okay? Now, how is this heart rate controlled? There are remember, it's under control of the autonomic nervous system. There's a cardiovascular center in the medulla. There is a center which increases the heart rate, which is called the cardio-acceleratory center, which of course has sympathetic connections. There's a cardio-inhibitory center, which brings it down, which has a parasympathetic connections. And there's also another center in the medulla, which is called the vasomotor center. This vasomotor center has sympathetic connections, as the name suggests. Vasomotor, motor to the blood vessels. So this is under sympathetic control. And for most part, it causes vasoconstriction, because remember, that was the function of the sympathetic nervous system, right? Vasoconstriction. So heart rate was number of beats per minute. Let's look at some other terms. End diastolic volume. As the name suggests, the volume present in the ventricles at the end of diastole. So if we look at this picture up here, the heart is relaxing. See, all this blood that fills at the end of diastole would be the end diastolic volume, right? When the ventricle contracts and pushes blood out with each beat, the amount of blood that is pushed out with each beat or each stroke is what is known as stroke volume. Okay? So end diastolic volume, as the name suggests, is the volume at the end of diastole. Stroke volume is the volume of blood that's pushed out by the ventricles. So here, when the ventricle is contracted, this volume which is pushed out at each beat or each stroke. End systolic volume, as the name suggests, is the volume of blood which is left behind after the ventricle has contracted, pushed out its stroke volume. So this, in other words, is the residual volume that remains in the heart, right? So you have a certain amount of blood at the end of diastole, which is end diastolic volume. The heart contracts, the ventricle contracts, then pushes out a certain amount of blood, which is stroke volume, right? This is stroke volume. What is left behind, because the heart cannot push out all the blood, it's not like it's going to completely empty itself. If it completely empty itself, what will happen? The ventricular walls will just collapse, which we don't want to happen. We want some blood to be left behind in the heart, right? So if we take mathematically end diastolic volume, we start with that, we remove stroke volume, what is left behind would be called end systolic volume, meaning at the end of systole, the volume that is left behind in the heart. Got that? Okay? Next is something called cardiac output. It is the blood flow of the heart, or the blood that is sent out of the heart in a minute. So this is the amount of times the heart beats per minute and the volume that is sent out with each beat. Okay? Cardiac output is the amount of blood that gets out of the heart, that flows out of the heart in 1 minute. So what would it be? Amount of times the heart beats per minute times how much blood is pushed out in each minute, right? That is cardiac output. So it's heart rate times stroke volume. So you can understand that if you increase heart rate or increase stroke volume, you would increase cardiac output. But we will see that if you increase heart rate too much, you really cannot increase stroke volume. The stroke volume will go down automatically, because if the heart beats too fast, there's no time for it to relax in between the beats. If it doesn't relax in between the beats, what happens? The end diastolic volume will be less. So stroke volume will decrease. Okay? So let's see now the factors which increase cardiac output. So again, if on the top, cardiac output is equal to heart rate times stroke volume. So within reason, if we increase heart rate or we increase stroke volume, we automatically can increase cardiac output, right? So let's see how we can increase stroke volume. Stroke volume is dependent on how much blood there is in the ventricular chambers. The blood there is in the ventricular chambers is known as end diastolic volume, right? Before the ventricle contracts. So if you increase the end diastolic volume, if you have more blood in the chamber, obviously you can push out more blood, right? So if you increase end diastolic volume, you automatically will increase stroke volume. More blood, you can push out more blood. If you have 70 ml of blood in the ventricular chamber, you can push out 50. If you have 50 ml of blood in the ventricular chamber, maybe you can only push out 30 because you have to leave some blood behind. Do you see that? How would you increase end diastolic volume? That means the blood that has, first you have to increase what comes into the heart. Remember, veins were taking blood back into the heart. So if you increase venous return, for example, during exercise, when people exercise, their muscles contract, they squeeze the veins in the legs, the blood goes up into the inferior vena cava. From the top, it comes down by gravity, so there's no problem. So it goes, more blood will be pushed into the inferior vena cava, more blood will go into the right atrium, which means more blood will go into the right ventricle. Okay, so exercise helps. If in fact you sit for a very, very long time, your blood pools in your legs. And in old people, what happens is when this blood pools and they stand up suddenly, you might have heard of your grandparents or older people saying, I feel a little dizzy. That's because the blood is pooled in their legs and they can't go up into their heart. So, and their reflexes are not as strong. So that's why they kind of have a little phase of dizziness. So we always tell old people that, get up very slowly. If you increase the length of diastole, that means you increase the amount of time the heart relaxes, right? If you increase the timing, if the diastole length, let's say, was 10 seconds, the heart can only fill in those 10 seconds. If you increase it to 12 seconds, the heart can fill much more because you're giving it more time to relax. Do you remember when we did systole and diastole? I told you that systole was of a fixed length because it used energy. Diastole was variable. You can change the diastole. So if you increase the diastolic length, automatically you fill the chamber with more blood. And that's really what happens in the athletes. In athletes, we will see that because the heart rate is low, the heart gets more time to relax. When it gets more time to relax, it fills with more blood. So athletes tend to have a greater stroke volume. So imagine in an athlete, if this is 40 beats per minute, the systolic volume will go up way more. Maybe the systolic volume can go up to 100 ml. In an ordinary person, if this was 70 beats per minute, the systolic volume may be something like 30 or maybe 40. So you see that you decrease this, but you can increase the stroke volume. So that's how athletes help to maintain their cardiac output, because they have a very great stroke volume. Another way to increase stroke volume is increasing the contractility of the ventricle. The Frank-Starling law is very similar to what you did with skeletal muscle. Skeletal muscle, you remember those actin and myosin filaments? And when the muscle contracted, the actin and myosin filaments overlapped each other. But if you increased the resting length of the skeletal muscle, so if you remember actin and myosin, if this was actin and myosin was in between here like this, if the overlap to begin with was not much, so you increase the resting length, the muscle can contract even better, right? So if you stretched it, it can contract much better because then it can overlap to a greater degree, which is why we say when you go to the gym, you must stretch before you begin your exercises. The same holds true for cardiac muscle. According to the Frank-Starling law, when you stretch cardiac muscle, it will contract better. So if you increase the end diastolic volume, if the ventricular chambers were filled with more blood, what will happen? Wouldn't the ventricular wall be stretched? When the ventricular wall is stretched, it will contract much better. So can you see the relationship with that? And so that helps in the contractility of the ventricles. So that is just by increasing the end diastolic volume. The second way the contractility of the ventricles can be affected is by sympathetic stimulation. The sympathetic nervous system not only increases the heart rate, it also increases the contractility. It has a direct effect on the contractility. It stimulates the cardiac muscle to contract better. The parasympathetic system only has an effect on the heart rate. It doesn't affect contractility much. Parasympathetic decreases the heart rate. It doesn't do much for contractility. Certain hormones and ions too act on the contractility of the ventricle and make it contract much better. For example, epinephrine, norepinephrine, these help. Some steroid hormones help the contractility of the ventricles. So that was stroke volume. Then let's look at heart rate. So if we increase the heart rate also, so we said cardiac output is stroke volume times heart rate. So here, stroke volume, we looked at ways to increase stroke volume. Now let's see ways to increase heart rate. An increase in heart rate of over 100 beats per minute is called tachycardia. So increasing your heart rate could be done by sympathetic stimulation. And when does this happen? When you exercise. So even you would have noticed, like when you exercise, your heart kind of tends to beat a bit faster. So you want it to contract better. And here you can see why in an athlete you do not want the heart rate, the resting heart rate to be very high. Because let's say for you, say any normal person, so let me take me, I'm not a great athlete or anything, though my heart rate is actually around 58, just because I go to the gym regularly. But say let's say start with 60. From 60 beats, maybe when I exercise, it'll go up to 72 because it's not like I need that much oxygen to my tissues. But imagine somebody who's playing tennis, like Roger Federer. His heart rate, let's say, starts with 40. When he exercises, if he also started at 60 like me, his level of exercise is so great, he might have to go up to maybe 120. At 120, the heart would perhaps be ineffective to send blood and oxygen to his tissues. So that's why he starts at 40, and then if he goes up to 72, the heart can still contract effectively. So athletes tend to increase their stroke volume more than they really do their heart rate, okay? So for us regular people, so we can see during exercise, the sympathetic system is stimulated as also in athletes, and that increases your heart rate. Stress also tends, any stressful situation, stress always stimulates the sympathetic system, which stimulates the heartbeat. And you may have noticed if there is, say you get into an accident or something like that, you get a little stressed out, you might have noticed your heart pounding, okay? And then there are baroreceptors in the atria. Baroreceptors are pressure receptors. These baroreceptors in the atria, when the pressure inside the atria increases, these receptors get stimulated. And what do they say? When will the pressure increase? The pressure will increase when there is more blood in the atria. So think of what the heart is going to say to itself. Oh, I have more blood in the atria. I need to get rid of this extra blood. What would be one way of getting rid of this extra blood? If I increase my heart rate, I can push more blood out. So baroreceptors in the atria help to stimulate the sympathetic nervous system and again get your heart rate up. Sometimes, like I said earlier, if your heart beats very, very fast, like in a case of what is known as ventricular fibrillation, In ventricular fibrillation, the heart rate is extremely high, more than 160 beats per minute. The heart is literally quivering. It's like a bag of worms. It cannot beat effectively. It doesn't relax in between. So with the result, even though your heart rate may be, say, 210, if your stroke volume is going to be only 10 ml per minute, can you see how ineffective the heart is really going to be? So let's take a look at ventricular fibrillation, and this will show you.
The heart usually beats about 60 to 100 beats per minute. With each beat, your heart pushes blood throughout your body. The upper chambers, the atria, contract at the same time. Then the lower chambers, the ventricles, contract at the same time. Ventricular fibrillation often starts with a fast rhythm in the lower chambers of your heart, called ventricular tachycardia. It is caused by a problem in your heart's electrical system. Ventricular fibrillation is a very fast rhythm in which your heart beats 200 to 300 times per minute. When your heart beats this fast, it is merely quivering rather than actually beating. Less blood and oxygen is pumped to your body and, most importantly, to your brain. Ventricular fibrillation is the most dangerous arrhythmia because it often leads to sudden cardiac arrest and sudden cardiac death.
So you can see how it was just quivering. No blood was actually really being pumped out of the heart. So it's extremely dangerous situation to be in. So you always want to kind of shock the heart and bring it back to its normal rhythm. Then certain hormones and ions again increase the heart rate. Epinephrine, norepinephrine are some of the things which do that. Thyroid hormone also increases the heart rate because it kind of makes the receptors more sensitive to epinephrine and norepinephrine. Another thing which helps, and this was, we were doing when we were doing blood vessels, is the resistance in arteries. Normally when the heart contracts and the ventricles contract, and where do they push blood? Into arteries, right? Pulmonary artery and the aorta. You do not want the pulmonary artery and the aorta to resist the blood which is coming to them. So if the pulmonary artery and aorta's resistance is low or normal, blood will be pushed out more effectively. Okay, so you always want them to be normal. However, imagine if the pulmonary artery or the aorta were blocked because of, so let's say this is the aorta. Look at this. This is blocked because of a plaque formation. There's fat deposit here called atherosclerosis. Now can you understand resistance in the aorta will be high, which means when the heart contracts, it has to push against this resistance, so it cannot push out much. So again, it will affect cardiac output. So you always want resistance to increase cardiac output. You want to make sure that the resistance is normal to low in the arteries. Let's look at factors which decrease cardiac output. So they'd be exactly the opposite. Anything which decreases stroke volume or decreases heart rate would bring down your cardiac output. So decrease in stroke volume would be decreased venous return. For example, sitting for an extremely long time, like, if you go on a long flight from here to Australia, I don't think there's a non-stop flight, but if you did manage that. But even, from here to London, 10 hours, you didn't get up. You were sitting all the time. When you keep sitting for a very long time, the edge of the seat presses against the back of your thighs, so it actually tends to kind of compress the blood vessels. Plus, muscular contraction. Remember when we talked of the blood vessels from the lower part of the body, because they have to go against gravity, that's why they have valves, they need skeletal muscle activity. So if you're sitting and not doing any work, that's why they always tell you to get up and walk after a few hours. But let's say you sat for these 10 hours without doing any activity, the blood tends to pool and less venous return going to the heart, which means your cardiac output would decrease, right? Or maybe somebody who's sick, bedridden for a very long time, again, their cardiac output would decrease because they're not working, which is why anyone who's bedridden for a long time, people will come and always massage their legs, or they'll put those little machines which kind of squeeze their calves and make sure that the venous return improves. This we just saw, decreased ventricular filling due to extremely rapid heart rate. So we saw in ventricular fibrillation, very rapid heart rate. The diastole is so less that ventricles will not fill, automatically a stroke volume will decrease. Suppose you have something which prevents the heart from, nothing wrong with the heart itself, but there's something wrong with the pressure outside the heart, like in the pericardial cavity. So let's say the pericardial cavity was filled with fluid or filled with blood, sudden stab wound or something fills blood into the pericardial cavity. So the pericardial pressure increases. What will happen? It will push on the heart. So it will not allow the heart to fill, which means then obviously the heart cannot contract effectively. So raised intrapericardial pressure will affect stroke volume. High blood pressure, that means, as I said earlier, if there was resistance in the artery. So imagine if the pulmonary artery or the aorta had plaque formation, or for some reason the elastic tissue in them was calcified, so they could not sort of dilate. There's increased pressure in them. That leads to hypertension. So now the ventricles have to contract against this resistance. They're not able to do that, so they push out very little blood. So again, stroke volume decrease. Decreased contractility. Usually decreased contractility is because of their heart muscle has died in that part. So that's usually due to myocardial infarction. So if someone suffers a myocardial infarction, that area of the heart tissue, cardiac tissue is dead, cardiac muscle is dead, that part of the heart is not going to contract. So in other words, that chamber of the heart, part of that chamber is not functional, so your contractility will decrease, which means obviously your stroke volume will decrease. In cases like congestive cardiac failure, congestive cardiac failure, and I mentioned this when we were doing cardiovascular anatomy, so we look at the chambers of the heart. So let me just take the tricuspid and the mitral, and here's pulmonary and aortic. So imagine if this valve was stenosed or narrowed. Blood from here will not be able to flow into this. So what will happen? It will have back pressure and go into the blood vessels in the neck. The superior, all the blood vessels which drain into superior vena cava will be engorged. All the blood vessels going into the inferior vena cava will be engorged. So the liver will feel tender, the lower limbs will feel swollen, you'll have edema. So this is called right-sided congestive cardiac failure. On the left side, imagine if the mitral or the aortic, either one of these was narrowed, but let's look at mitral. What will happen? Left atrium to left ventricle, blood will not go through, so this will backtrack into the lungs. So the lungs will be congested, right? So you'll have left-sided heart failure. So in either case, you can see that not much blood is coming to the ventricle, so automatically less will go out. Let's look at decrease in heart rate, which is called bradycardia. Anything less than about 60 beats per minute is bradycardia. In athletes, they have what is called physiological bradycardia. That means it's not true bradycardia, it's physiological, because they have a high vagal tone. So that's why under athletes I've put it in with an asterisk. That means there's nothing wrong with them. This is just physiological. But otherwise, in someone in whom there's an extreme parasympathetic stimulation, some people, when they go into a panic attack, instead of the sympathetic being stimulated, it could be parasympathetic stimulation occurring. And, they stop breathing, the heart rate falls at that time. Extreme cold temperatures, you go into a freezing lake or something, your heart can stop actually. So that again is can decrease your heart rate and cause bradycardia. Certain ions also can do the same thing. So all of these can decrease your heart rate, with the result they will decrease your entire cardiac output, okay? So let's take a look at this statement and tell me which of the below is incorrect. Okay, well, most of you got this right. Exercise will not decrease stroke volume. Remember, exercise will increase stroke volume because it increases venous return. A very high heart rate will decrease stroke volume. Why? Because a very high heart rate, I told you, will make the diastolic period very, very short. With the result, the heart will have less blood in it, so it can push out less. Increasing the contractility of the chamber and reducing resistance. So you make it contract better and the pathway out is easier. That will help stroke volume. So this is a true statement. This one was the false statement. Exercise increases stroke volume and increases cardiac output, doesn't decrease it. So you've all heard, people who go for an EKG. So this is just a first level anatomy and physiology class. You're never going to read an EKG at this level, but I just want you to kind of look at it. Basically what you do is you measure the electrical activity of the heart. This is what a typical EKG looks like. There's a little wave up here called P wave, which is due to atrial depolarization. Then you have this complex going down like this called QRS complex, which is ventricular depolarization. And then you have another wave after that called which is due to ventricular repolarization. So take a look at these two pictures. This is normal. You can see this is how it is normal. Look at this one. See how these T waves are going so way up compared to these, right? So you can just by looking at it tell that it's abnormal. I'm not ever going to give you one of these to ask you to diagnose which is normal, which is just to show you. If you put a stethoscope on your heart, you hear that lub dub sound. Those are called heart sounds, and they are due to the closure of the valves. The first heart sound is due to closure of the AV valves, and the second heart sound is due to closure of the aortic and pulmonary, which are semilunar valves. Remember, these were semilunar valves, so that's due to that closure. And in your head, you must think, when do the AV valves close and when do the semilunar valves close? Remember, we did that during systole and diastole. I possibly have a question on that. So here it is. So when do you think the first heart sound will be heard? So the first heart sound is because of the closure of the AV valves. So this is how you must relate the information. Beginning of systole, I can see why some of you must have thought, okay, end of diastole and before beginning. It's at the beginning. It's when the heart contracts, the first thing to close is the AV valves, and then you push the blood out. So, okay, at the beginning of systole is when the AV valves will close. Okay, let's look at this. What would be the physiological result if the mitral valve was narrowed? So I'm kind of taking you, as you can see, through the cardiac cycle and all that I've told you so far. So cardiac cycle helps you to answer 50% of the questions. So really know that well and work your way. Pedal edema means edema in the feet. Very good. Yes, there would be backup in the pulmonary veins, because if the mitral valve was stenosed, left atrium would dilate, backtrack into pulmonary veins in the lungs. So that's what, both ventricles won't hypertrophy. The ventricles are getting very little blood. So a hypertrophy, they would if they have too much, or they have to push against resistance in the arteries. So they don't have that problem. Now let's look at another concept in physiology, which is blood pressure. So the pulse is the pressure wave that you feel passing through the arteries. You know, when you take somebody's pulse in the radial artery, or you take it in the carotids, or you take it in the dorsalis pedis, it's just the pressure wave that passes through. Blood flow is the milliliters per minute, which is what we take as cardiac output, always goes from an area of higher pressure to lower pressure. That's why it kind of passes down the arteries. And when we look at blood pressure, again, just as when we looked at the contraction of the heart, we had systole and diastole. Blood pressure is also taken as systolic at the beginning of systole and diastolic at diastole. Systolic will always be higher than diastolic. So systolic is the upper number that you have. So when you say somebody's blood pressure is 120 by 80, 120 is the systolic blood pressure, and 80 is the diastolic pressure. Pulse pressure is the difference between these two. So that's 40 millimeters in someone who has 120 by 80 blood pressure, okay? There also, we say blood pressure is 120 by 80. Every individual is different. When you're much younger, your blood pressure is usually lower. So for people to have a blood pressure of 90 by 60 is not abnormal. To have something by 80 by 60 again is not abnormal. That's your individual blood pressure, and that just says that it's very good. It's not low blood pressure, okay? Low blood, typically when you say someone has low blood pressure, that's because they have lost a lot of blood. So from their normal, the blood pressure has come down. You had a question?
Yes. Like when someone is smaller, their pressure is lower, right?
Not necessarily. When someone is smaller, their pressure is lower. But if they are, if you say they are, take two individuals who's slim, one person who's slim and another person who is also slim but much bigger made, like taller, yes.
Okay.
Yeah.
And then people who are heavier, their pressures are higher mostly?
Most of the time, because
Medical issues?
probably, most of the time, those who are heavier, there's more resistance in their arteries because there are more blood vessels. Remember, and we'll do that, the length of the blood vessel matters. If they are more obese, it's quite more than likely they have atherosclerosis, which increases the resistance, so your pressure goes up, okay? Which brings us to, how is blood pressure measured? And this might answer your question. Blood pressure is measured obviously by the amount of fluid that is flowing through the blood vessel. The amount of fluid that's flowing through the blood vessel would be the cardiac output, whatever the heart is pushing out. That's the amount of fluid that flows through the blood vessel, and the resistance that is offered by the blood vessel. So again, I love to give this example of a garden hose. So take this example. Imagine you have this kind of a garden hose, this wide, and or let's take a look at these two pictures. Imagine these were two garden hoses. This is one which has this diameter, and this is a garden hose with this diameter, and you pushed fluid through them, right? Over here you can see the blood will flow out very easily, okay? And it will not come out at great pressure. Up here, the blood will come out at great pressure, which is why what do you do when you want to water far? You put a nozzle at the end of your hose, because you're decreasing the diameter so that the pressure builds up and you're able to kind of go through a longer distance, okay? So you can understand, and this is based on flow. So this is the flow in a blood vessel which is kind of wide. So this kind of flow is known as laminar flow. When the vessel is very narrow, you can see all the blood is kind of very close to the walls, and the walls offer resistance, and then that's why the pressure builds up. So PR stands for the resistance which is offered by the blood vessel, or also called peripheral resistance. By the periphery or the walls of the blood vessel. We already know what factors increase or decrease cardiac output. So since we say blood pressure is cardiac output times peripheral resistance. If your cardiac output increases, automatically your blood pressure will increase. If your cardiac output decreases, your blood pressure will decrease, right? So we know that. Imagine if somebody was exercising, their cardiac output increases, their blood pressure will increase. If on the other hand, somebody lost a lot of blood, The cardiac output, if you have less blood, less will go out. Cardiac output decreases, blood pressure decreases, which you can understand. If someone has a hemorrhage, you see all these shows like Grey's Anatomy and whatever. Oh, the blood pressure is dropping because, the less blood, okay? Let's look at peripheral resistance. Let's see what are the factors which will increase, or factors that peripheral resistance depends on. One is viscosity of the blood. Viscosity is like thickness of blood. And I think maybe in the lab I gave this example. Thickness is like comparing water to honey. Anything which is thicker or more viscous tends to flow more slowly and offer more resistance, right? So the thicker the blood, the more the resistance there will be in the blood vessel. Now you cannot thicken blood like you honey or thing, but the way in your body that you can thicken blood is if you have more cells in the blood, like for example polycythemia. If you have more red blood cells, can you understand how it's like the blood will be more full? If someone has anemia, there's more fluid and less cells, so the blood will be kind of thinner if you were to compare it, okay? But don't ever tell someone you've got thin blood because you have anemia. That's not a wrong term, but I'm kind of trying to show you that if the more cells there are, the more viscous the blood is. The less cells there are, the less viscous blood is. The diameter of the lumen is this cavity. We just determined that the smaller the lumen, the more the resistance. The larger the lumen, less the resistance. So we can see that vasoconstriction up here, increased contraction will increase peripheral resistance. Vasodilation, when the vessels dilate and the diameter increases, the resistance comes down. Blood flows out more easily. Length of a vessel. Shorter vessels, blood has to go short distance, less resistance. Longer vessels, imagine blood has to travel all that distance. So the blood vessels are offering resistance all the way through. So longer the length of the vessel, the more the resistance, which might explain your question, like, someone is a tiny person, someone's very large, they have probably larger blood vessels, got to go more surface area, more resistance in those cases. So let's look at this, how the lumen diameter.
Atherosclerosis is the buildup of fatty plaque on the inside of the arteries. This buildup narrows the artery and impedes or blocks blood flow. Ultrasound imaging shows the blood flow in the arteries. Get screened and share this video with a friend. Visit.
So you saw over there, when it was narrowed, obviously blood has to kind of try to push against that narrowed opening, which means that the resistance builds up, which automatically means your blood pressure goes up. And another factor with that is you saw how the plaque, it can keep increasing, which is why hypertension, which travels like this, when blood pushes against that resistance, sometimes a blood vessel can rupture. So somebody who has atherosclerosis, especially in the arteries of the brain, you can see that the blood pressure is building up so much in them because the blood is pushing against resistance. Those blood vessels can rupture, and that's what ends up in stroke. So that's why one has to get screened regularly, and you must treat hypertension at all times. So let's look at some questions here. Do you think blood doping, we did blood doping when we did blood. Do you think blood doping would increase peripheral resistance? So think back, and what is blood doping, and do you think it would increase peripheral resistance? Yes, very good. It would increase peripheral resistance. For those of you who didn't get it, remember blood doping is when a person removes their blood, stores it, and then their body manufactures, gets back their blood volume and their blood cells, and then they retransfuse them. So they're really causing polycythemia. And apart from the fact that you're cheating, and it's, you're at an advantage compared to somebody else who's not doing it, because you have more cells, so you can provide more oxygenation to your tissues. It also has its problems, because now blood becomes more viscous. So your resistance goes up. When blood becomes more viscous, can you understand, more cells, they can get stuck in smaller capillaries and blood vessels, and you could get clots there, which could, cause problems in whichever organ. What do you think would be the result of anemia on peripheral resistance? Anemia will decrease it. If polycythemia increased resistance because it made blood more viscous, anemia means less cells, blood is less viscous. So it decreases it. Okay, another question. Now everybody should get this. Ooh, some people are still not listening. Peripheral, you have narrowed the blood vessel. So when you narrow the blood vessel, remember I said it just takes more pressure to pass through a narrow opening. So you'll increase your blood pressure. And that's how atherosclerosis causes high blood pressure, because it artificially narrows it. It doesn't even need the sympathetic system to do that. It artificially narrows it. And this is one way that the body helps. See, if somebody loses a lot of blood, let's say somebody is in an accident, they lose blood. What happens? Less blood, your blood pressure will fall, isn't it? Because cardiac output will drop, your blood pressure will fall. If your blood pressure falls, blood is not going to flow to important parts of your brain, of the body, like the brain and the heart and so on. That's when it's a stressful situation. So what happens? The sympathetic system actually kicks in. What it does is it immediately narrows all the blood vessels. When it narrows the blood vessels, your cardiac output has fallen, but peripheral resistance has gone up. So it tries to maintain the blood pressure for some time. It cannot do it endlessly, but it gives people enough time to get help, and that's when you start pushing, because you've lost fluid, you start pushing fluids in and, bring the blood pressure back to normal. Yeah.
Does giving blood affect any of this, or do you, if you're only giving a pint, it really doesn't matter?
No, if you have a lot of blood, so you can give.
Blood drive today, by the way.
Yeah, you can give blood without really, having any effect. The volume that you lose is very little. They just tell you to make sure that you've eaten before and so on, and that's because of hypoglycemia and the stressful situation of giving blood. But it has nothing to do because of people who have not eaten and they give blood. Usually might feel faint. That's because of the hypoglycemia that they have, not because that they've lost a pint of blood.
Okay, so I wanted to add a question on that. If someone is taking a lot of medications or on drugs, like abusing them, does that affect blood when you give?
I mean, if you're abusing a lot of, sorry?
Is the blood going to be contaminated with the medications that?
Oh yes, of course. If somebody is on drugs,
Yeah.
I would hope that a bank would test and they would ask. I mean, they would.
I'm just wondering, like.
Yes, it would. Of course, all of what you eat, all of that goes into your blood. It's, it passes into your blood, and that's how it actually reaches the tissues where it has an effect. So if you, for example, smoke weed, it finally goes into your blood, and that's how it kind of reaches the tissues, gives you that nice buzz. I don't know what the buzz is, but I'm just telling you. So, but it goes into your blood. So if somebody is taking drugs, medication, usually they take a long history before you give blood. You're advised not to give blood because that medication is in your, in your blood, and that could be passed on to whoever, gets it. Yeah. You should, no person on medication or anything should really give blood, because, you would affect the person that it goes to, the recipient.
If it's antidepressants, would that be beneficial?
That also there is there. All medications are there, and there may be some that they say, like, you know, vitamins and so on, it's okay, but any of these other things, they might, if you've been off of it for a few days or so on. And here's the other thing, someone on antidepressants, you don't want them to donate, they themselves probably won't want to donate blood. It's a stressful situation, so, you know, it kind of has a lot of other neurological symptoms, and so it could precipitate something else, you see, so you got to think of it that way too. Yeah. So let's look at regulation of blood pressure. So since blood pressure was cardiac output times peripheral resistance, so anything that interferes with either of these would regulate blood pressure. So we saw already cardiac output regulation, you know, all the things. So anything which interferes with cardiac output would interfere with blood pressure. Let's look at peripheral resistance. So this is kind of a bit of a review. So one is the short-term neural controls, which is the diameter of the lumen, which I just told you, because of the sympathetic nervous system, you know, the vasomotor tone. If the tone is more, vessel constricts, your blood pressure goes up. If the tone is less, vessel dilates, blood pressure comes down. Distribution of blood. This is another way to, again, which has a lot to do with the sympathetic nervous system. And again, this is neurological. So let's say, for example, that on a restful day, right now, our class begins at 9:30. You probably had breakfast when you came here. So now all your food is in the digestive tract. Digestion has to progress. So what happens is that you may have noticed immediately after eating a full meal on a regular day, in cold weather, you begin to feel a little cold. The reason is that because your digestive tract, after eating a meal, your digestive tract needs the blood. Blood is shunted from your skin and it goes to the digestive tract. When it goes away from your skin, you begin to feel a little cold, because here the blood vessels constrict in the skin, but they dilate in the gastrointestinal tract. So right now you're all sitting nice and happy, and you know that's where the blood is. But if suddenly the fire alarm went off and your blood, you had to rush out of the room, digestion would stop. The blood would be moved from the gastrointestinal tract. It would go to the brain, to the cardiac and skeletal muscles, and digestion would stop. So you can see how the blood can kind of be shunted around, constrict somewhere, dilate somewhere, and that's how pressure can be changed in those areas. Okay? The other are chemical controls, and we'll look at this video. Decreased, or anything which decreases oxygen or increases carbon dioxide, that kind of has an effect on the resistance. A decreased oxygen to any tissue means you want the tissue to dilate so that more blood can go there, so that it can snap up as much oxygen there is. Or if there's increased carbon dioxide, again, you want to remove all that carbon dioxide from that area so that, you know, it can be removed from the body. There are hormones which we will do when we do the endocrine system. There's a hormone called ADH, antidiuretic hormone, also known as vasopressin, then epinephrine and norepinephrine, and angiotensin. So these three hormones, this is also known as vasopressin. And you know, if you start looking at names now, it'll help you. Vaso means blood vessel, pressin, press, tense, okay? So what do you think vasopressin will do? Vasoconstrict. Angio, blood vessel, again, blood, something to do with this. What do you think angiotensin will do? Tensor, again, vasoconstrictor. See the name, angiotensin. Epinephrine, you know, it's one of the neurotransmitters at the sympathetic nervous system, so these are vasoconstrictors. So these three are vasoconstrictors. This ANP is something known as atrial natriuretic peptide. ANP stands for atrial natriuretic peptide. It's something which is formed by the atrial walls. The word, what is natrium? Very good, sodium. Uretic, uresis means urine. So that means sodium is being passed out in the urine. When sodium goes out, it takes water with it. So an atrial natriuretic peptide actually removes sodium and water, so it actually decreases blood pressure. All these three increase peripheral resistance. ANP decreases peripheral resistance, so it decreases blood pressure. Alcohol and inflammatory products. Alcohol by itself causes vasodilation. You may have seen people who drink a lot, they tend to have very flushed faces, or even if any one of us had a few drinks too many, our face tends to get flushed, right? We also get dehydrated. Vasodilation occurs, and the dehydration is because alcohol causes that ADH to be secreted. And inflammation, you've noticed anywhere in your body if there's inflammation, that area looks red because the vessels are dilated. When vessels are dilated, you can see both of them will decrease peripheral resistance. Then under control of blood pressure, kidneys, these kidneys are short-term controls are neural, and we'll look at this. So this is really short-term, where you want to quickly take care of it. So that is either because of the sympathetic nervous system, or you have these chemical controls because of oxygen and carbon dioxide or hormones. But long-term control of blood pressure, if there's a problem and it needs to kind of be taken for a real, taken care of long-term, this is done through the kidneys. So if there is more fluid in the body, the kidneys will cause more urine to be passed out. So this is a direct mechanism. So more fluid in the kidneys excrete more fluid. So the kidneys help to do that. Or there is something called the renin-angiotensin mechanism, which is an indirect mechanism. And this kind of helps in actually maintaining blood pressure. Renin-angiotensin mechanism. And I'll give you a brief introduction. We do this more when we do the endocrine system and when we do the urinary system. And this is how all the body systems are kind of locked in together. So to give you an example, somebody loses blood, right? If someone has lost blood, what did I say? There's hemorrhage, the sympathetic nervous system causes vasoconstriction, blood pressure goes up, right? Now, and you know, for some time homeostasis is maintained. Another thing that happens is someone has lost blood, less blood goes to the kidneys, because if there's less blood everywhere, less will go to the kidneys. In the kidneys, the arteries of the kidneys, they recognize that less blood is coming to them. At this point, do you want the person to be passing more urine? No, you want to conserve as much water, because as it is, you've lost fluid. So you want to make sure that you're not urinating a lot at that time, right? Conserve urine. So your kidney, that's how your kidneys take care of it. So since less blood is going to the kidneys and the kidneys sense it, in the kidney, in the blood vessels of the kidney, they secrete this hormone called renin. This renin goes into the general circulation and causes another hormone called angiotensin to be secreted. Angiotensin by itself, angiotensin constricts blood vessels and causes vasoconstriction, right? Plus renin-angiotensin also actually goes and secretes another hormone called aldosterone, which causes sodium and water to be reabsorbed from the kidneys. So you pass less urine. So can you see how the kidneys help? Because if you're passing out less urine, you keep more volume inside the body, so you help the cardiac output. So that's how the kidneys help. Yeah.
And when people are on dialysis, the kidneys stop doing this process, right?
Well, people are on dialysis, yes, the kidneys can't do all of this. The kidneys have failed. They have done something. So when someone is on dialysis, obviously the none of the kidney mechanisms, that's why they can't even produce erythropoietin, they can't do all of this. So they need to kind of take care of that. Let's look at two terms. Hypotension, which is low blood pressure. Hypotension is, as I said, it's not a disease. You do not say that I suffer from low blood pressure. You can suffer from high blood pressure when your blood pressure is actually, nowadays they say anybody more than, I should really change this number, anybody a little bit over 120 is pre-hypertensive, and a little bit over that then we say is hypertensive. 90 millimeters again you take as hypertensive. Hypotension is low blood pressure, when your blood pressure falls, systolic blood pressure falls below 100. If your normal blood pressure was 90 over 60, when it falls really low. So you know, if you have, like my normal blood pressure is about somewhere around 86 over 60. So people will always ask me when they measure that, is that your normal blood pressure? And I say, yeah. So if mine then falls to 60, then I have hypotension. Okay, so I can't give you a number really. So from your normal, if it comes down, and that is because of either hemorrhage or diarrhea or severe vomiting or dehydration, and your blood pressure falls. So you can see that it is momentary. But hypertension is a condition that a person can live with, where the blood pressure is sustained and kept high. Oh, let's go back and actually look. I want you to see these neural controls. Okay, I guess not. They've removed that. Okay. So hypertension is defined in two ways. There's a primary hypertension, which is the most prevalent type of hypertension. We do not know why it occurs. We think some of these could be the problem, that either you inherit it. Certain races are more prone to hypertension than other races. A lot to do with diet. The more fats you eat, the more obese you get, the more cholesterol is deposited in your arteries, and it causes atherosclerosis. You get hypertension. The older you get, the more likely you are to get hypertension, because the older you get, the arteries become less elastic. The elastic tissue is replaced by calcification, and that is known as arteriosclerosis. So, you know, someone who's 80, their blood, and someone who's 20, and if they don't have any other problems, the person who's 80 is likely to have a higher blood pressure as compared to someone who's 20. Diabetes, mellitus is important because diabetes affects blood vessels. It causes microvascular changes in blood vessels, and that's how it leads to hypertension, and that causes lots of problems in the eyes, in all your blood vessels of the body, in the kidneys, and so on. Smoking, because nicotine by itself causes vasoconstriction. So again, that causes hypertension. Stress, any kind of stress, you know, normal little stress causes hypertension just for a short time. But someone who's under chronic stress for a very, very long time will become hypertensive, because stress releases hormones like cortisol, which cause vasoconstriction. So again, you have that. Secondary hypertension is because there's a probable cause for it. So this is usually lesser of the, this is more prevalent. Most of the time we say the person has primary hypertension. Secondary is there could be a cause. Maybe they have some kidney problems, and then, you know, the systems are not working properly. Or maybe they have a tumor of the medulla of the adrenal gland. That tumor is producing epinephrine and norepinephrine. So there's vasoconstriction. Or someone has a thyroid problem. Excess thyroid hormones also causes hypertension. So, you know, these are some problem where you can pinpoint because of this the person has hypertension. So let's take a look at some of the effects.
Blood pressure is blood flow, the volume of blood pumped out of the heart per beat multiplied by arteriolar resistance to the blood flow. Blood flow depends on the rate of heartbeats and the volume of blood pumped out with each beat. If rate or volume increases, blood pressure goes up. Likewise, increased resistance raises blood pressure, as when arteries downstream from the heart constrict. Over time, high blood pressure or hypertension damages many organs. First, the heart works harder to pump out more blood, or against higher resistance. The heart then requires more oxygen and is more susceptible to angina or a heart attack. Second, arteries and arterioles can be damaged. Arteriosclerosis results when blood moves through arteries and arterioles at high pressure, damaging the vessel. White blood cells are drawn to the damaged area to form plaque. Third, kidneys can be damaged. The capillaries of the kidney are delicate. Continually subjected to high blood pressure, they break down, becoming permeable to proteins and other molecules. The kidney's tubules can become clogged, decreasing the kidney's ability to make urine. Also, the proteins injure the capillaries' membranes, causing more damage and worsening the situation. Fourth, the retina of the eye can be damaged if its delicate capillaries are damaged. Localized hemorrhages can occur, causing scarring and formation of new imperfect capillaries to replace the old ones. Finally, the blood vessels of the brain can be injured. High blood pressure can cause clots to break off from atherosclerotic plaques, blocking blood flow to the rest of the brain. This is called a thrombotic stroke. Continual exposure to high blood pressure may also cause a blood vessel to burst, leading to a hemorrhagic stroke.
So this slide, it looks very busy, but this is a really good slide. So pay attention to this. So we saw how the neural control of blood pressure was. So if you take something like this, say, let's say the blood pressure has fallen, the stimulus is blood pressure falls below normal. Present in your carotid arteries, which you did, there are receptors there which measure this pressure. These are known as baroreceptors in the carotid arteries and the aortic arch. These baroreceptors, your blood pressure has fallen, so what do you want to do? The body wants to raise the blood pressure. So these baroreceptors, they send impulses to the vasomotor center where the sympathetic system is active, and they stimulate that and cause vasoconstriction. And then what they do is they decrease the impulses from the cardioinhibitory centers. And then your blood pressure, your cardiac output increases, your resistance increases, and your blood pressure comes to normal. Let's say your blood pressure is extremely high. Again, the baroreceptors sense this. So they want to bring down your blood pressure. So they want the sympathetic system to go down. So what they do is they increase the receptors. They go and they inhibit the cardiostimulatory center and stimulate the inhibitory center so that the parasympathetic system becomes active. So when the sympathetic system is kind of calmed down, your blood vessels will dilate, your heart rate and cardiac output will decrease. So all these which raise blood pressure will come down and your blood pressure comes back to normal. Okay. So take a look at this picture. Looks really busy, but it's really very, very explanatory. So let's take a look at this. Which of the following would be a way the kidneys control blood pressure? So BV stands for blood volume. So if there's increased blood volume, does it lead to increased filtration and increased urine formation? Or if there's increased blood volume, there's decreased filtration and decreased urine formation? Increased blood volume. If there's too much blood volume, what does the body want to do? It wants to get back to normal. The only way you can do that is if you remove it from the body. One way of removing it is to increase your urine formation, right? If there was decreased blood volume, what does your body want to do? Conserve urine. So decreased blood volume means decrease going to the kidneys, less urine. But here I gave you the thing where there's increased blood volume, and you would have seen this when you drink a lot of fluids. What happens? You're increasing your blood volume because that gets absorbed. You tend to pass more urine. If you're dehydrated, you would have noticed what happens. You pass less urine. So kind of try and, relate this to your day-to-day life.